Assalamu alaikum, Mr. Bakhair. Good evening, everybody. My name is Ibrahim Sbeih. I'm a neurosurgeon, and we are transmitting live from Farah Medical Campus here in Amman, Jordan. Just to remind you, these are the Leonardo da Vinci anatomical drawings some 100 years ago. I think people know Leonardo DiCaprio more than they know Leonardo da Vinci. Orbital intraconal cavernoma is our topic for tonight, and that needs some anatomy because of the orbit, right orbit, left orbit. In the orbit we have the rule of 7, meaning 7 bones, 7 arteries, 7 veins. Bones are frontal bone, sphenoid bone, greater bone, zygomatic bone, maxillary bone, lacrimal bone, ethmoid bone, and the palatine bone. And the arteries, of course, the thalamic artery, the central artery, anterior, ethmoidal, posterior ethmoidal, supratracheal, supraorbital, and the angular branch of the fascia, with their corresponding venous drainage. So rule of 7 in the orbit. Severe wall is made by the frontal bone, and there we have the ethmoid bone making the medial wall. Inferior wall is made by the maxilla, and the lateral wall is made by the sphenoid bone. If you look at the severe orbital fissure, and this is the optic canal. The optic canal is not seen in the straightforward look at it, so you have to move the skull a little bit to see the optic canal. But this is the severe orbital fissure, this is the inferior orbital fissure. Notice the relationship with the maxilla. So here we are seeing the optic canal and the severe orbital fissure. And this is the maxilla. If you take the maxilla out, the anterior wall, then you will see the rest of the severe orbital fissure, and you will see the foramen rotundum, and you will see immediately the foramen for the vein of canal, median canal. We are looking at the left eye. Why did I choose the left eye? Because we are talking about left eye pathology, the patient with left eye pathology. So the eyelid, the tarsal plate, there is a tarsal plate in the upper lid and the tarsal plate in the lower lid. And if you go into the apex of the orbit, you will see the annulus gem, the optic nerve, and the muscles coming out of it. This is the lacrimal gland laterally. So these are the muscles. This is the globe. This is one on the left side. And you can see the severe oblique, the severe rectus, the medial rectus, inferior rectus, inferior oblique, lateral rectus. And if you see the cut, this is the left orbit, this is the globe, you will see two muscles. The severe rectus, on top of it there is the levator plata plexus superioris. Here is the medial rectus, here is the inferior rectus, inferior oblique, lateral rectus, and this is the lacrimal gland. These are the femoral veins. So you'll see the optic nerve with its central artery and vein, and around it there is subarachnoid space and the dura. Again, lateral rectus, medial rectus, superior rectus, inferior rectus, levator plexus superioris, superior oblique, and how it looks on the image. If you look at it from the top, on the left side, right side is here, midline left side, you'll see bone, which is the orbital plate of the frontal bone. If you remove that, you will come to the periorbital. If you remove the periorbital, you can see a nerve underneath the periorbital, which is the frontal nerve. Remove the periorbital, you will see the periorbital fat and the nerve, frontal nerve. Remove the periorbital, remove the fat. You see the two muscles, levator plexus superioris, underneath it is superior rectus. Medial is medial rectus, lateral is lateral rectus. This is the lacrimal nerve going to the lacrimal gland. Anatomy that can be done by God itself cannot be done by anything else. There has to be a creator who's done this beautifully in the fashion it is done. So the globe, the optic nerve, and the various nerves. This is the oculomotor nerve, the lacrimal nerve, central artery, and the giving us anterior thymoidal and posterior thymoidal and anterior thymoidal artery. It's a complex anatomy, but once you know it, it's easy. Again, you're looking from the top, right orbit, left orbit. And if you make a cut here, you'll see the globe. And these are the muscles, medial rectus and lateral rectus. So we speak of the cone. Cone means the cone, like the ice cone, ice cream cone. So anything inside this is called intraconal, anything outside it is called extraconal. So lacrimal gland is extraconal. There is fat in the extraconal space, fat in the extraconal space. Here is the optic nerve, fat in the intraconal space. And this is how it looks on the images, the globe, the optic nerve, the lateral rectus, the medial rectus. So this is called medial compartment, intraconal. This is called lateral compartment. This is lateral compartment, this is medial compartment. Again, if you look at the sorry for that. If you look at the orbit laterally, again, I'm concentrating on the left orbit anatomy. So you will see the zygomatic arch. This is the lateral wall of the orbit. You open it, you'll see the periorbiter. You come with the periorbiter like this. So this is the left orbit as seen from the lateral view, and this is the periorbiter. Remove the periorbiter, you'll see the lateral rectus. Here is the inferior rectus, here is the superior rectus. Why am I showing this? Because you'll see it in the movie. So you better acquaint yourself with this anatomy. We'll be going between this muscle and this muscle here to remove the tumor. So the lacrimal gland, the globe, the lateral rectus, and we'll be going into this space. If you don't know the anatomy, you will cause havoc to the patient. You will destroy your patient. Anatomical knowledge is essence. Is the essence, actually. So basically, this is it. The globe controlled by these muscles: inferior obliques, superior obliques, rectus, inferior rectus, lateral rectus, medial rectus. And here is, we have cut the lateral rectus. You can see the optic nerve, the ciliary ganglion, the long and short ciliary nerves, and so on. If you have a cut like this is the globe, this is the optic nerve, this is the fat, which is within the cone of the muscles. And if you follow, this is the superior rectus, this is the levator laterally superioris, and there it divides into two parts. Part that goes into the upper eyelid, and part that goes into the tarsus of the upper eyelid. This is called molar muscle. So who's interested in the orbit? Everybody. Of course, the ophthalmologist, the oculoplastic, and I just want you to watch that. There's only, I think, one ophthalmologist here tonight, although they have all been invited. We just don't want to hear anything about it. Neurosurgeons and neurologists are very much interested. We always say the eye is the window of the brain. If you look into the eye, you'll see lots of pathology. Maxillofacial, the ENT, the oncologist, the interventional radiologist, the radiotherapist, and the internist. Internists are very much interested in the orbit with all these autoimmune diseases and so on. So it's a common ground for so many specialists. But I have to tell you, this was originally the land of the neurosurgeon. Dandy used to do all his orbital lesions on his own. If you look at the pathology, you would see by just looking at the orbit, this is orbital cellulitis, foreign body. Look at this. The same look, this is the pseudotumor orbital inflammation, autoimmune disease, very much like this. For this, thyroid orbitopathy. Here are a group of tumors that look the same. So you have to be careful. And people who say, oh, this is rare, this is nothing rare. In medicine, everything can face you, everything can come across you. So we'll talk about the orbital problems in terms of diseases or tumors. tumors, inflammation, infection, congenital diseases, vascular diseases, and this, the disease of the orbit, which is the idiopathic orbital pseudotumor. Many people don't know about the existence of this. Thyroid ophthalmopathy, the lymphoproliferative disease, the Wagner granulomas, sarcoidosis, amyloidosis. How many of us in this room remember the amyloidosis? IgG4 disease, Mikulicz disease, which can affect all the salivary glands. So our topic for tonight is the orbital tumors. So we'll speak about the primary orbital tumors. They are rare. And it's the best to think about them in terms of structures. What tumors affect the globe? Neuroblastoma, uveal melanoma. What tumors affect the optic nerve? Meningiomas and gliomas. What tumors affect the intraconal? Hemangioma. Extraconal, these carcinomas, rhabdomyosarcoma, etc. So there may be extension from the bone and the sinuses to the orbit, or there may be something affecting multiple compartments. This is the best way to think about orbital tumors. This is a very nice paper, review of 244 orbital tumors in Japan, published 2004. 244 cases, 213 were primary orbital. So primary is more than the secondary. Extraconal is more than the intraconal. Remember the pathology that affects the lacrimal gland. It's huge. And this is the 213 primary orbital tumors. What is the commonest? Lymphomas. Lymphomas and lymphoid hyperplasia. What is the commonest in the intraconal orbital tumors? Meningioma, glioma, optic sheath meningioma. What is the commonest in the extraconal lymphoid? Lymphoma. People forget about lymphoma. It's there. So if we look generally at what are the adult orbital tumors, malignant. Lymphoma, malignant hyperplasia, and pleomorphic adenoma, adenocarcinoma. While if you look at the pediatric group, it's mostly benign. 80% are benign. Dermoid, glioma, meningioma. So adult tumors are usually malignant. Pediatric tumors are usually benign. This is the message. So in children, 80% are benign, 2% are malignant, 20%. One case published in the Indian journal, Indian Ophthalmology Journal. Indian Ophthalmology Journal. Do we have Arab Ophthalmology Journal? No, because we don't believe in research and papers. We just want to get money and do no research, know nothing about progressive medicine. India is very, very aggressive in their publications. Pediatric tumors of the orbit, 2013, and pediatric neurosurgery. In the neurosurgery journals, we have the adult journal, we have the pediatric journal, we have the spinal journal, we have the minimally invasive. 4 journals from one institute, which is the CNS. So 30 pediatric patients in this period of time, majority are benign. Another paper in general, 122 patients in this period of time from Poland, mostly malignant adults. This is my daughter Lucille. Hello, Lucille. This is from Poland, Makowski, 122 orbital tumors, mostly malignant. So, what is Cavernoma, which is our topic for tonight? My interest in Cavernomas goes back to 1986 when I published this paper in the journal of neurosurgery. I was just still starting my neurosurgical career. I just finished my residency. That's Journal of Neurosurgery, 1986. Why? I was forced to do this paper. I was crying, please, boss, give me time. I want to read for my exam, saying, hell, you go and do this paper. So I had to do the paper and I passed the exam. So we work under pressure. This is when I was at the Atkinson Memorial Hospital. At that time they used to be called cryptic AVMs. So this is the paper. To publish something in the Journal of Neurosurgery, If you publish one paper, you are something. So it is called Cavernoma. Forget all about these terminologies. They are gone. Nobody is using them. Cryptic area, because they were not seen on angiography. Cavernous malformation, snout. Occult malformation. Cavernous angioma, cavernous meningioma. No. The terminology that's accepted internationally is Cavernoma. Still, you see the radiology report speaking about cavernous meningioma. It's called Cavernoma. It's a tuft of lizards, endothelial lizards, like this. They grow by angiogenesis. They are ovoid in shape. They have pseudo capsule. So it is said there are tangle of bristles that resemble a blackberry. They do look like blackberry. And I love blackberry, but I don't eat these. These are tumors that are excised. What is the difference between Cavernoma and the cranial or the orbit? Major differences. Behavior is different. The cranial Cavernoma is different from the orbital Cavernoma. Orbital Cavernomas are encapsulated, rarely bleed. Cerebral Cavernomas are usually not capsulated and usually bleed. Common in females, which is lucky for us males. Why? Because they have progesterone receptors in the epithelial cells. The age is this, 30 to 60 years, but remember it can happen in children. So this is the progesterone receptor expression in the orbital cavernomas. It is established. They have progesterone receptors in the epithelial cells, and the epithelial cells of the cavernous meningioma. Just like they have progesterone receptor in meningiomas. That's why both are common in females. Remember that in children, you can have the orbital cavernomas coexisting with these cutaneous or choroidal cavernomas. So whenever you see this, maybe they have something inside. Locations, anywhere in the orbit. Different, I've chosen different cases, so that they can happen anywhere. But they love the outer compartment. This is their favorite site. The outer compartment. But they can be interosseous, within the bone, inside the bone. They can be intraorbital and extraorbital in the cavernous sinus and outside. Like this paper from Italy. Can they be bilateral? Yes. It says, are bilateral cavernomas do exist? Are they real? Yes, they are. So they show these cases of bilateral cavernous meningiomas or cavernomas. Bilateral orbital cavernous meningioma, still using the old name. This is published in the Asian Journal in Tunisia. Tunis are active in north of Africa. Tunis and Morocco are active in publication far more than Egypt and Libya and others. So they put the literature where they have bilateral orbital cavernomas, the authors and the cases. So bilateral cavernomas do exist. If you have a case and you want to treat it and send it for the insurance company, they'll say cavernomas are congenital, we don't treat it. Why? Because insurance company, they play games on us, doctors, and play games on doctors. They just want to gain some money. So they say, oh, this is congenital, we don't treat it. Tell them it is not congenital, it could be acquired. It could be acquired like inheritance like this, autosomal dominant. What about the radiology of the cavernomas? CT, MRI, ultrasound, FPG, PET, PET scan, and SPECT. There is something called the Frankfurt line or Frankfurt plane. This is the middle fossa, anterior edge, middle fossa, anterior edge. This is the greater window sphenoid. If you draw a line like this, here you are in the apex of the orbit, here you are not in the apex. This is the most difficult part of the orbit to operate, orbital apex. The rest here, easier than this one. And once you do that line, beyond it, you compare, you divide this by 120 degrees, 120 degrees compartment. A is called superior lateral, B superomedial, C inferior. So now you can speak the same language. Where is the tumor? You can say exactly what it is. T1 isointense to T2 hyperintense. It is well demarcated, it has pseudocapsule, and you better do fast suppression even after contrast. Different images of the cavernomas, how they look in different sequences, T1, T2, etc. And this is called fiesta. Fiesta because you can look at the whole length of the optic nerve. So this is the globe, this is the optic nerve, so you look at the whole length from anterior, or the whole length from posterior. What about contrast enhancing? If you give, this is before contrast enhancing, initially some enhancement, and then there is late enhancement. Remember this, small enhancement, bigger enhancement to there. So-called progressive enhancement.
So by instance,
Please.
how you can differentiate between hemangioma, and cavernoma? It's the same as the pattern of enhancement.
Yes,
Every
yes.
stage can be enhanced.
They are the same. Cavernomas and caverns, hemangioma are the same. They are the same different labels, but we are speaking of the same pathology. So SPECT can be delayed uptake. Angiogram, you better look at the ophthalmic artery and see the branches, how it's done, whether it supplies the tumor or not. You will see the venous drainage here from this tumor going into the cavernous sinus. And here, this is a beautiful view. You can see the carotid, you can see the ophthalmic artery going like this on top of the optic nerve and then going this way. So it goes this way and then this way. Here, because there is a tumor, it is compressed. So angiography can be of great importance. How do they manifest these tumors? Protrusion or proptosis, it is 100%. If the tumor is more than 1 centimeter, you will have proptosis. Limitation of the eye movements, double vision, decreased visual acuity, redness or swelling, headaches, or retroorbital pain. You can see the proptosis. You can use something called proptosis index. See the angle here and the angle here. Or as I said, you draw the line at the back of the globe or the Frankfurt line. When you want to see the proptosis, you always look from above. Here, of course, it's so obvious. The right eye is proptotic. But if the proptosis is minimal, the best view is this. Right eye is proptotic. Here, next to sheet. Same thing. Left eye. So maybe here you miss it, but this way you will not miss it. Tangential look. Put the patient in a chair and look onto. Again, you will not miss this, but here, look the difference. Same here. Look at this here. You may find signs of increased intraocular pressure. And we have to stop using the palpation method. This is old method. Oh, yes, the pressure is normal. You have to measure the intraocular pressure. You can look into the fundus and you can find papilledema or optic atrophy or choroidal folds. Sometimes they present acutely, although they don't read, but these are cases against the rule. They bled. Acute presentation of cavernous hemangioma of the orbit by bleeding from USA. Again, the treatment involves all these people. It is not for ophthalmologists, it is for all these people. Cooperation will lead to progress. Sometimes you need to do needle aspiration, fine needle aspiration. It's important diagnostic examination that should be performed whenever there are no conflict indication. I'd like to call upon Dr. Farida Adham to also tell us about the aspiration and maybe using the thing for treatment.
Thank you, Dr. Ibrahim. It's always a pleasure to be here again, and always interesting to learn something new. Aspirating these lesions, we rarely ever have to do it to diagnose it, because I think with the imaging characteristics we have, almost always you can come to a good assumption of the diagnosis. But I was asked to talk about, is there another option besides the major surgery you will see later about the case you presented, because there is different ways to treat these patients, and depending on the patient situation, the minimal invasive ways does have good actually results, and may help patients avoid some significant surgery as the one that you will see next. So I will not go into details about the science behind it or the history and data. I will show a case, a patient that we did and the results for this patient. This is a 36-year-old, an engineer, had proptosis for a long time with some actually difficulty in right nasal passages, and he actually underwent an attempt of resection that was aborted due to the bleeding issue. So he lived actually after that for years, not knowing what to do, consulting people. So eventually was referred to us for evaluation. So this is the MRI of the patient. As you could see, we have a type of lesion where there is a well-defined multilobulated lesion, intraconal, large lesion resulting in compression of the optic nerve, which you see part of it here. The lesion does extend almost to the orbital apex. It's obviously causing significant proptosis, and very typical characteristics. Not on the T1 image is low iso to muscle, high T2, and we'll see the enhancement. This is one of the interesting cases because it has the multi-compartmental extension of the lesion, because you have the intraconal compartment and you have extra orbital compartment inside the nose. Very similar characteristics. This was when at time of surgery, actually a piece was taken of that and was by pathologists read as cavernous hemangioma, which is Cavernoma. This was this is both contrast, and you see the enhancement in this lesion. This is T1 both, and they are enhancing avidly. They are strongly enhancing lesions. And characteristic-wise, they fit the diagnosis of pathology. So pathologically and imaging, and 6 years almost between the time of surgery and the time I saw him, he was having the same issues, not much progression. And angiography was done in another institution, and that was negative for any high vascular abnormality. So you have such a large lesion, and I would, if the time would have allowed, we would have asked Dr. Ibrahim as a neurosurgeon how would he approach this lesion. This is a large lesion that will typically present a significant challenge from the surgical approach, especially that this has multi-compartmental approaches. So the way we approach this is relatively in a minimally invasive way. This was obviously evaluated by the ophthalmologist, all and an oculoplastic person have seen him before, specialist, and his intraocular pressure was slightly elevated. He had actually effect of the optic nerve to a mild degree. However, when we discussed the treatment, we offered him a novel technique of treating these lesions, which essentially percutaneous access into the tumor. That's what you see an example here. So we bring the patient in, we access it with just small needles under ultrasound and fluoroscopy guidance. This is obviously the orbit. We under ultrasound we access these lesions by needles, and this was injected with bleomycin. Bleomycin, as you know, is an anti-tumoral and antibiotic, but most of the people remember it as an anti-tumoral, anti-cancerous treatment. It has a lot of characteristics that has been proven over the years that it has an effect over these lesions, and actually has significant effect over multiple vascular lesions, not only cavernomas. The challenge with such a patient is making sure that you have control over the intraorbital pressure. intraocular pressure because you don't want to leave it. These cases are done with the ophthalmologist in the room, measuring the intraorbital pressure before we start, after anesthesia. While we are injecting, there is actually a way where they measure it with a pen, and we have a very strict control of the intraocular pressure. So what you will see here is an example how we access. If you look at this, not knowing the AP view, you would think there's a needle going through the globe. It's actually obviously going alongside the globe into the tumor. If this works, you will see right now some of this will illustrate not available for some reason. This would illustrate the injection of contrast inside the tumor. You see the blush here of the tumor. This is the needle inside the tumor. This is contrast. We inject contrast to assess the location, the spread of the treatment that we will offer inside the tumor, and as well in where is the drainage, where does that medication will go? Would it stay in the tumor? Is there actually extension of it into the cavernous sinus? And that has indication on the treatment. I would love to see if this video will work, but it will not. Moving forward, this is again showing the frontal view. As you could see, this actually needle going next to the globe intraconally into the tumor. Contrast injection showing that location. Obviously, we see the globe very clearly with ultrasound. With fluoroscopy, you don't have that access. So this patient underwent 2 sessions of pleomycin injection into the tumor, and that was done purposely. We treated the anterior aspect of the tumor first, shrink that, and then we treated the more posterior aspect next to in the apex of the orbit, and that's how things looked. So this is how he looked before treatment, first session, and second post the last session. It was this patient was have a dramatic improvement with only 2 sessions. As you could see, almost the intraconal compartment almost clear with a very, very small residual of this tumor. His proptosis dramatically improved. The interesting part, which we saw when we were treating him, is that if you look at the intranasal compartment, that was here. Eventually, if you look at the last image, it shrunk more than 80% because of the communication. This is again post-treatment, post-second stage. You see that there is the nerve now completely free. There's nothing pushing on the nerve. So if you look before and after, this is how he looked before. This is how he looked after. This patient proptosis resolved. His optic nerve had normal functioning. So he had, luckily, he didn't have long-term damage. And for now, he avoided surgery. So this is one technique you could use to treat such lesions. This applies to multiple sites, not necessarily intraorbital, but this is obviously very a critical site, but we implement this in a lot of times, different places in the body, especially critical places. Thank you for the opportunity, Dr. Ibrahim.
So you now know of a new technique, another technique, alternative technique for this thing. Okay, so surgery is the mainstay, but remember that if you find this incidentally, it doesn't mean that you have to remove it. It has to be symptomatic. And the aim of surgery is to take the tumor totally in block and avoid injury to the surrounding structures. If you have a case and give it to the ophthalmologist, he will use transconjunctival or the lateral orbital. If you do it in neurosurgery, you use the transcranial or lateral orbital. But there are so many approaches: transconjunctival, supraorbital, lateral orbitotomy, transcranial, transantral, and endoscopy. Anterior approaches: transconjunctival. This is the right eye. This is the medial aspect. You can cut the medial canthus and proceed inside. This is the anterior ethmoidal artery. Transconjunctival for this lesion. You do flap of the conjunctiva and then you slide inside. Transconjunctival from South Korean. this tumor, again, with the cryoprobe. Another transconjunctival from Turkey, large tumor. Transconjunctival again, South Korea. This is the globe. They have one here. This one, right protrusions. This is the tumor taken out through the conjunctiva. Same thing here. Sometimes they put some kind of cotton loop around the muscle so that they can pull it and see the relationship with the muscles. You can do the vertical lid like this, vertical lid, and then go through transconjunctival. You can go supraorbital, just to take the supraorbital limb of this left orbit, and then go into the orbit itself. Or you can use the lateral orbitotomy, the lateral wall of the orbit. This is the left orbit. You can remove the lateral wall like this. You cut here at the frontozygomatic or the zygomatic orbital here, suture, remove this bone, you'll gain more access. And then you can fix it with these small pieces. Lateral orbitotomy from Turkey. When you mention orbital tumors, you have to mention the name of somebody, which is Joseph Maron. Joseph is a friend of mine. He's from the Maronites of Lebanon. He's a great man, a great leader, and he spent his life doing orbital surgery. He's a neurosurgeon. So if you look at the publications, you can find most of the publications done by himself and his group. As again, to mention it again, neurosurgeons were the masters of the orbit. And then came the others. This is another paper of the lateral orbitotomy from Iran. You can use transcranial. We usually use the frontoorbital or fronto-orbitozygomatic. And you can go like this, frontal lobe, temporal lobe, and then you have the whole orbital frontal view like this. You can see the orbital front. It's a beautiful view. You can have the full control of the orbit wherever you like to go. But you have to have good anatomy knowledge. Endoscopy, the cretin, and it's important. It's used for biopsy or excision of small benign lesions. That's how it started. But then it just rocketed sky high. Seeing light, endoscopic endonasal intraconal orbital tumor. You go into the small sinus and then change direction and you go to the orbit. This is from the Carl Schneiderman group, Schneiderman, Gardner, and Mikasam. Endoscopy for this tumor is the carotid artery, optic nerve, and then the mass in the apex. Endoscopy, transnasal. This is a very famous paper now, and it is from USA, published in the Journal of Neurological Surgery. And look at this cooperation. We in this part of the world don't believe in cooperation. It's a solo game. I am the one, and the others should die. It's not like this. Paul Gardner and Schneiderman are endoscopists. Joseph Maron is a neurosurgeon. Fernandez Miranda is an ENT surgeon. They are playing together to give us the list. They call it round-the-clock cervical access to the orbit. You can reach anywhere through this approach. And they give you examples. من الساعة 12 للساعة 1 من الساعة 1 للساعة 2 regions according to where they are and how they can approach it. Beautiful paper. Joseph Maron now is in retirement. He's doing some yoga classes. Endoscopy in the nasal or transfemoidal approach, again from Japan. And you can use it for malignant tumors, again from Japan. This is endoscopy for resection of locally aggressive tumors. From here you can go this way, or this way, or this way, or this way. Endoscopy is the future of neurosurgery. If I am a resident, I would choose to go into endoscopy from now. Again, different examples of different lesions and how they approach it by endoscopy. Just reading this paper gives you insight into new anatomy. It's a very pleasurable feeling. My series of intraorbital tumors, 120 cases, 85 since I came from England till 2018, mostly females, benign tumors 72, malignant 28, others 26. Examples of cavernomas. 40-year-old male patient with this cavernoma, before surgery and after surgery, and here he is. Another male from Jordan, 30-year-old male with this tumor causing proptosis. This is the surgery and this is the postoperative. And this very, very challenging case of orbital apex cavernoma, which we use intradurally, transcranially, very difficult case before surgery and after surgery. Our case for tonight, I'll go through quickly. This male patient, 42-year-old male patient, Jordanian, he had headaches and proptosis. That's the man with no limitation of eye movements, just the proptosis and the headaches. Images showing this tumor. As I said, cavernoma, they love the lateral compartment. So this is the optic nerve being pushed. This is the lateral rectus. Optic nerve being pushed. It is attached. It is in touch with the optic nerve. The most drastic complication for this surgery is blindness. Imagine you do surgery for this patient and you get him blind. It's a disaster. And you get him blind simply because you don't know anatomy and you have not been well trained. So that's the tumor and the coronary view. So this is the two muscles, Sbeih rectus, levator palpebris superioris, medial rectus, levator rectus, inferior oblique. This is the optic nerve. So I know where to go. I'd like to go this way, between this muscle and this muscle, bilateral orbitatomy. If you give it to a ophthalmologist, he would use transconjunctival or possibly lateral orbitatomy. So it's the concept that you do it. And in combination, it would be nice. I love to have the ophthalmologist and the vision auxiliary surgeon with me. And I love to use navigation. It is a teamwork, it's not a solo thing. So this is the lateral view, and this is the tumor. Again. The study of the images with the your anatomy knowledge gives you the courage to go in and operate on this patient. And we did angiogram, the MRA, and you can see again, this is the ophthalmic artery coming off the dorsal aspect of the internal carotid artery of the carotid cave. It goes like this through optic canal, above the optic nerve, jumps over it, and then through medially to give the posterior femoral and the anterior femoral, and ending with the suborbital arteries. What is the differential diagnosis of this case? Easy. You'd find that it is not easy. All these are cases that has been pathologically proven. So I'm not lying to you, I'm not putting new labels. These are pathologically confirmed. This is lacrimal gland tumor, retinoblastoma, sinonasal carcinoma, capillary hemangioma, dermoid, one of my cases. Adenoma of the lacrimal gland, adenocystic carcinoma, mucoepithelial carcinoma, osteoma, osteoblastoma of the orbit, ameloblastoma, starting in maxilla going into the orbit, osteosarcoma, giant cell tumor involving the whole of the orbit, rhabdomyosarcoma of the orbit, yes. There is pathology like this, but because you don't know, you don't think about it. You just look into the activation, هاي حساسية شوية تطلع وروح. Sinonasal carcinoma, squamous carcinoma, undifferentiated carcinoma, lacrimal gland pathology, clavus involving the orbit, angiofibroma involving the orbit, histiocytosis, and this is one of my cases which we presented, Venous malformation looking like a tumor, venous malformation of the orbit. Sphenoorbital meningiomas, one of my cases involving the orbit. Neurofibroma involving the frontal branch of the trigeminal of V1. Hematoma, just hematoma due to trauma. Idiopathic perineuritis, Peltit's disease of the bone of the orbit. Fibrous dysplasia, one of my patients, Iraqi patient. Inverted papilloma, sinonasal fibroma, it's a benign disease. One of my patients, chondrosarcoma, supraorbital vein dilated, looking like a tumor. Lymphangioma with fluid level. Nasopharyngeal carcinoma, enterocystic carcinoma, rhabdosarcoma, Ewing sarcoma, nasopharyngeal. Laryngosarcoma, chondrosarcoma, metastasis. Metastasis and nothing different. Metastasis love to go anywhere, so they can go anywhere. Lymphoma, which we always forget about. Disease neuroblastoma coming from the nasal area. Ductal carcinoma of the lacrimal system. Plasmacytoma, one patient of mine. Fungal infection, one patient of mine. Allergic rhinitis, orbital cellulitis. Sarcoidosis, perpetual disease, mucocele, fungal infection as we mentioned, echinococcus granulosus in the orbit. I put this group together, otic gliomas, different sizes and shapes. Here they are affecting the optic tract. Meningiomas, this is the easiest part, or the simplest part, or the earliest part. It's called the tram track sign, like a tram line. This is involving the optic nerve, some nodules. This is large tumor and so on. Thyroid orbitopathy, as if it has gone. It is not. You're still seeing thyroid orbitopathy, with the muscles and the fibrous tissue being thickened. And the forgotten disease really is the idiopathic orbital pseudotumor, so-called pseudotumor. It is autoimmune disease inflammation, dacroadenitis involving the lacrimal gland, involving the ethmoid, involving the lacrimal gland again, bilateral Sigurdsson syndrome, causing dryness of the eyes, dryness, sinusitis, inflammation as mentioned. Tolosa-Hunt disease, again autoimmune disease like this, optic neuritis, is involvement of the cavernous sinus, scleritis, and perineuritis, all for Tolosa-Hunt syndrome. So you see, we don't think of these differential diagnoses simply because we don't know, simply because we don't want to know, because this would put burden on us to read and keep up to date. I challenge so many neurosurgeons who just finished their neurosurgery board exam, if they have come back to any book to read or any paper to read, they've just finished the exam, they are consultants, and they just proceed through life with ignorance.
Can we go back to the
course.
images, please? I'd like to add to the differential,
Dr. Hasimi Al-Hadidi, Chief of the Department, Jordan University Hospital.
The hemangiopericystome is the one which appears similar. You can't differentiate between the cavernoma and hemangiopericystome. The other one, which is slightly difficult to differentiate, is the lymphatic proliferative disease. If we go back to the images, which Dr. for the same patient, the only thing you have to always to ask your radiologist is to do images without with fat saturation except the T2. Okay? If we go the images here. So first, this is with contrast. T1. This is not accepted to be done without fat sat. The images to see the enhancement, you don't need a long time for cavernoma. Cavernoma do enhance in 2 to 3 minutes. So you don't wait for 5 minutes, 10 minutes like hemangioma on the liver. Usually you do image every 30 seconds to see the complete. Usually within 3 minutes, it is completely opacified. Can we go, please? Here, this is T2, and it is done fat sat. It is not good. You should see T2 without fat sat to see the chemical shift. The chemical shift is very good for you. It will show you the pseudocapsule of the lesion. Next, please. Here, this is T2, and this is without fat sat. Yeah. Here we are seeing the capsule, but we are not seeing the chemical shift. Okay. And this is without fat sat. This is done without fat, with fat sat, while these are done without fat sat. This is the T2, this is T1, all these T1, except this is the T2, which should be done without fat sat to see the chemical shift. Okay, that's it.
Now that raises a question, Azmi, should we write down to the radiologist what to do, or should the radiologist have the knowledge to do what he should do? I find it strange that radiologists look at these images after the patient has left the compound. It's not good. These pictures should be seen by the radiologist when the patient is still on the table. I always ask for the technicians of the radiology department to be available. Don't allow the patient to go home without consulting with your boss to see whether you need to do any further images. So these are the rest of the images in the differential diagnosis. We did a few consultations, Dr. Farid. You did the angiogram for this patient, and you found that there's a feeder from the left ophthalmic artery, and here it is. This is the ophthalmic artery and the feeder, and the rest of the angiogram. So we don't leave any stone unturned. We need to know everything about this patient so that we can operate safely and well. Good medicine is expensive medicine. Poor medicine is not expensive. Dr. Ibrahim Sadat was not available, he's traveling. He did the OCT for this patient and did the ophthalmology, which was within normal. And he was anesthetized by Dr. Abbas al-Tawil, who announced the patient set for general anesthesia. And this is the constant form. We mentioned everything about it. I did the lateral orbitotomy and I used the navigation. Surgery. Very short, we will finish before 8. So the whole thing will not take more than 2 minutes. So this is the left orbit. We have done lateral orbitotomy. This is the lacrimal gland. I am drilling here the suborbital rim to gain more access. He used the diamond drill, and I always keep telling the best drillers in the world, the ENT surgeons, and I learned how to drill from them. You drill with the side of the drill. This is the lacrimal gland. And I use the application. Here I'm retracting the lacrimal gland, anterior and lateral. I'm using the navigation probe to say exactly where I am. I know exactly where I am. This is here the superior rectus, here is the lateral rectus. I'm going in between. You don't like to use the bipolar diathermy because that would cause the fat to shrink, and if the fat shrinks, then the orbit will go inophthalmos. You want to preserve the orbital fat. Orbital fat is a nuisance. It is very ugly. It will hinder your dissection, but you have to know how to deal with it. So I know the tumor is here, and I'm digging actually for it, but I know exactly where I am. This is the superior rectus, on top of it is the levator palpebris superioris, here is the lateral rectus. I'm going in between this and this, lateral left side. There's no joke here. Either you know or you don't. But remember, orbit is in the domain of a neurosurgeon. You have to master it. Maybe you will not operate, but you have to master the anatomy and the knowledge of the pathology. And I tell you, you will go into the orbit on so many occasions. Do we train patients, do we train residents during the residence program in Jordan? No. Orbit is no, it's not for the neurosurgeons. And vessels are not for the neurosurgeons. Nothing is for the neurosurgeons. They just need to know how to do a shunt, how to do a disc, how to put screws in place. And this is not neurosurgery. This is general surgery. Now, this is the lesion. I'm opening it just to make sure that I am in it. I try to debulk it so that I can extract it without putting much pressure on the surrounding tissues. I'm sure now it is Cavernoma. I use the ultrasonic aspirator to debulk it from inside, and then I go around it. So here it is. It has to be removed in block, not in pieces, in one block. This and the AVM should be removed in one block. You add to them the hemangioblastomas. Hemangioblastomas, cavernomas, and AVMs should be removed as one piece. So here you are. هاي نسميها الحركة المسرحية مشان أورجيكم الليجن. And then this is the lacrimal gland, and this is the roof and the lateral borders. Okay. Mr. Pathology, the professor.
I will take a minute to mention Dr. Ibrahim mentioned about pioneer aspiration in the orbit. In my long career, doing thousands of pioneer, I did only 3 pioneer from peri-orbital area. For obvious reasons, many people they don't like to do the orbit. But one of them was a patient with leukemia, and he has orbital mass, proved to be invasive aspergillosis. The patient treated, but unfortunately he died eventually. One case was for metastatic carcinoma, and one case was for myxedema. Returning back to the case, this was the tumor. If you remember, this was in formalin fixed tissue. If you remember the original from the last thing that Dr. Ibrahim showed, it was a little bit more reddish in the before formalin fixation, because formalin fixation make thick tissue more shrunk and more like brownish in color and bluish. So you can see the difference when fixation is there, and usually it's less than usual. You can give it extra probably 20% before its fixation, and this is that was the hemangioma that was removed. You can see typically this is very much dilated vascular spaces. The abnormal thing about Cavernoma or hemangioma, the wall is abnormal. You can see with a vascular space like this, you expect the wall to be 3 or 4 times larger than this, but you can see they are really small, and they are arborizing channels between each other, and that's why they are easy to bleed, and you can see easily hemosiderin, and sometimes you can see some fat tissue in between. Again, you can see this is area that has been bled there, and fibrosis after fibrin formation. You can see recanalization again and again. This is typical the pathophysiology of cavernous hemangioma. Again, here you can see that it's reaching up to the edge, and that's why they sometimes bleed. And you can see the wall. This is not a normal wall. This is fibrous wall, and usually muscles they have the muscles are few if you do muscle stain, and these are arborizing channels of dilated vascular spaces. Again, you can see this is higher power, how these are very much dilated. Here you can see some hyalinized formation, fibrosis, and this is fibrin closing some of the channels. There are 3 major special immune stains that stains endothelial cells. CD31 is one of them. You can see the brown staining is the one that tells you that this is the wall of the endothelium of the vascular spaces. It's positive, as expected. CD34 is another one, and it's positive in the lining, brown staining. And we have also factor 8. Factor 8 sometimes it's weak positivity, some nerve twigs in between the tumor cells. So this tells you if you missed them by morphology by H&E, highlight them by the S100. B53 is usually negative. This is non-specific staining. K67 was less than 1%, indicated this is usually not appropriating tumor. So this final diagnosis was Cavernoma. Thank you.
Post-operative images, the very next day, we don't delay the images, the very next day, we do proper images and suitable lesions, so it's no tumor, bone work is nice. Actually, the little orbitotomy here. And the MRI, no tumor, process has gone. Preserve the neurovascular structures. And that's the patient. Of course, there is always periorbital edema and ecchymosis. This is for orbital. Ecchymosis is less. This is the discharge summary, detailed discharge summary that we are proud that we are one of few in the world who's doing this. Everything is done. The patient is put in writing. Dr. Mahmoud Nisa was resident then. Now he is passed his exams, then he is surgeon. Follow up 1 year. Beautiful. No problem whatsoever. And this is the cosmetic appearance. How it looks. With this we finish and I thank you. Any questions or comments? Please.
أنا دكتور بسام الخرمة، أخصائي تجميل عيون، بلاستيك سيرجن وأوربيتال سيرجن. أنا درس معنا دكتور إبراهيم بدون يعني friendly atmosphere, scientific atmosphere. This is our branch. This is our area. This is our bread and butter. This is what we're doing daily basis. يعني مش أنا خوفي إنه مش كل الجراحين جناب زي الدكتور إبراهيم بيعرفوا المعرفة والدكتور فريد. This is our specialty. This is our area. We know exactly each single يعني problem in the orbit. The worry is إنه هلا new generation يطلع ويبلش يتشاطر. Orbit at one time, as you said, Dr. Ibrahim, correctly, as always, was a neurosurgical specialty. It was. Nowadays, we're orbital surgeons dedicated for orbital surgery. We do only orbits. أكيد إنه إحنا عندنا exposure أكثر من new neurosurgeons. ما خلص احترام دكتور إبراهيم، دكتور فريد، شكرا لكم.
One taken, and it was mentioned and stressed that since then these days it's a neurosurgical field. St. Joseph Moreau, it's still in neurosurgical field, and then people came into it, including the endoscopists. The best thing is the cooperation between different specialties. You cannot say that this is ophthalmic, you cannot say this is pure neurosurgery. Each case has its own merits. And I just want to challenge you, Doctor, with this case, again in a friendly atmosphere, and we'll ask you, what would you do with it? The apical orbital apex, what is it? It should be here. This one.
Okay. Again, Dr. Ibrahim, in this particular problem, no single orbital surgeon should ever touch such a patient. This is your area, definitely, no doubt. بس لما يجيك دكتور إبراهيم patient pure orbital mass, for God's sake, حرام تفتحوا له راسه 4 hours.
No, Doctor, don't say تفتحوا له راسه الجمل مش صحيحة.
لا يعني
Doctor, hold on. This patient is a friend of yours or some acquaintance, and he came to you, and you recommended that he comes to me. So don't change words.
No.
When case come to you, you can operate upon it if you like. When a case come to me, I operate it when I like. These cases are for neurosurgeon. A lot of orbital surgeons, a lot of orbital pathology is for neurosurgeon. I agree, a lot of orbital pathology is for the ophthalmologist and oculoplastic surgeon. But don't mix and don't give wrong messages that this is an ophthalmology only. It is not. Any comment, please?
Dr. Farid,
if orbital venogram, is it helpful for the diagnosis of orbital tumors by superficially means orbital venogram? It is useful or not?
Probably the short answer is not. And the long answer is and with the imaging we have now between the MRI and the CT and with the conventional angiography that sometimes we do to clarify the nature of the lesion and the nature of supply to the lesion, we get a venographic phase of the angiogram, so we don't have to percutaneously stick a vein in the eye.
So angiography is good for any comments or questions? Please.
I want to ask Dr. Farid regarding intraregional Cavernoma injection bleomycin. Is it work for another place like brainstem Cavernoma?
I've never tried it there.
No.
So next time you have a brainstem one, you just open the skull for me, I'll stick it in.
You don't think it will work?
I don't know. I don't think anybody tried it.
No, but if they tried it, no one should try it. But bleomycin has been used in other tumors like Clarence chordomas or C1, C2 chordomas, etc. It's still not popularized, but it is being done. Any other questions or comments? Thank you. We'll meet next Wednesday.